Reddington Hospital in Lagos, Nigeria is a privately owned health establishment which has over time been associated with a number of groundbreaking accomplishments. The hospital pioneered Nigeria's first digital cardiac catheterization and angiography suite, a specialty in healthcare. Only 2 days ago, a team of surgeons at the hospital successfully carried out a complicated heart bypass procedure on a patient, the first of its kind, we're told, in the history of applied medicine in Nigeria. Reddington also boasts of a rapidly growing profile in other specialized areas like renal dialysis, obstetrics and gynecology, as well as pediatrics. But with this latest feat in correctional heart surgery, the hospital appears to have provided an attractive option to a steady stream of Nigerians who, before the arrival of coronavirus in Nigeria, were massively embarking on medical tourism abroad, spending scarce foreign exchange in the process and contributing to the worsening problem of capital flight. On the program today, we're now going to discuss all of this with three heart specialists from the hospital. Dr. Olutunde Lalude, who is Group Medical Director, Reddington Hospital. Professor Kamar Adeleke. Professor Adeleke is a consultant interventional cardiologist and chief of the Reddington Tristate Cardiology program. And Dr. Michael Sanusi, who is a consultant cardiothoracic surgeon and a member of the Reddington Tristate Cardiology program. Now, we try to find out from them how much work still needs to be done to encourage Nigerians to build confidence in Nigeria's healthcare system. Good morning and welcome to the morning show. But first, before we begin to engage, let us take this report by our rights correspondent, Adefemi Akinsoya, who was granted exclusive access to Reddington Hospital in Lagos during an open-heart surgery.
For us, we feel that the future is bright.
Faces of victory. These doctors are part of the team who successfully completed the first complex open-heart surgery at Reddington Hospital in Victoria Island. The life-saving 6-hour-long operation on a 66-year-old patient comprised 3 procedures in one. It was performed by Reddington's new Tri-State cardiac program, proving that despite the popularity of medical tourism in Nigeria before the outbreak of COVID-19, there is undeniable talent in the healthcare at home.
One thing I'm particularly proud of is the fact that this was a completely 100% Nigerian team.
It's a surgery called coronary artery bypass grafting, where we take blood vessels from other parts of the body and use them to replace the blocked heart vessels.
So it really underscores the need for collaboration and also to let Nigeria know that everything is here. So you don't need to be flying around and then to even be able to do it in this saga of COVID-19 when nobody could go from even one state to another. I think it's quite very, incredible.
Before the end of the press conference, an emergency heart patient is brought into the hospital and rushed into theatre upstairs. We were able to follow the doctors to the intensive care unit, where the heart surgery was already underway.
And he has been having chest.
Professor Kamar Adeleke left us to run into the adjoining room to direct the surgeons.
They call us right away.
Of the screen.
Go ahead.
Have you done that?
Stay there and then just deploy like that. That is perfect. Fantastic. Excellent. Okay. So, 55 years old, came in, with chest pain, and he was having a massive heart attack. So, massive heart attack, and there are 3 major arteries that supply the heart, 2 to the left and 1 to the right. The most important artery that supplied the front of the heart was the one we suspected. And we brought him to the cath lab, and indeed, he had 100% blockage. So you can see this one that goes to the back of the heart, this one goes to the front. This one here is supposed to come all the way down like that. So you can see right here, it's 100% blocked off. And then we did the angioplasty. That's the same artery now. You can see now the blood flow. By this evening, patient is going to be able to walk around.
And that optimism grows when we're told we can meet the patient whose surgery brought us into Reddington Hospital in the first place. But before that happens, we're given personal protective equipment to wear before a single step can be taken towards the recovery ward. Well, this is the moment we've all been waiting for. We've been granted exclusive access into the ward where the recovery is ongoing. We've come here to speak to the surgeons behind this groundbreaking surgery, and we've now been afforded the opportunity to speak to the patient himself. We've been asked to sanitize our hands one more time, and then the moment arrives. We make the journey into the room. Inside is a quiet yet hearty Olutunde Adeleke. He's been through a marathon surgery. His heart was stopped while he was put on a heart-lung machine which pumped blood to the rest of his body. Surgeons then opened his heart to repair the affected valve. His 3 blocked arteries were then successfully bypassed, restoring normal blood flow. And after all of that, naturally, my first question to Olutunde was a simple, how do you feel now?
I feel very great. And I thank God for giving me the opportunity to live. In fact, I would say I can't even remember how I get here. It's God's doing. It's God's making. And He is the only one that knows the beginning from...
So take your time, slowly. Take your time, slowly.
Can you give me a pair of gloves, please?
Did you ever think that quality care would be better outside of Nigeria, and do you still feel that way now?
Honestly speaking, I didn't even believe there's anything like this that can happen in Nigeria. It's marvelous in my eyes. It's unbelievable.
As he rises to his feet to display his strength in recovery, he says a prayer for the doctors, nurses, and healthcare assistants who stood by him along his life-saving journey. Doctors say, as long as there is investment, support, and belief in Nigerian healthcare, Oluwatunde's success story won't be unique. The resounding consensus here at Reddington Hospital is that home is definitely where the heart is. Adefemi Akinsanya, Arise News, Lagos.
Congratulations.
Well, that's the report by our correspondent Adefemi Akinsanya on the cardiac surgery carried out at the Reddington Hospital. And now we have joining us Dr. Lalude, Professor Adeleke, and Dr. Sanusi, who were part of the team that recorded that major breakthrough at Reddington Hospital. Good morning.
Good morning,
Dr. Lalude,
doctors.
Professor Adeleke, and Dr. Sanusi.
Good morning.
Good morning.
Good morning. Well, Professor Adeleke, let me start with you. This day newspaper yesterday on its front page described the surgery, the cardiac surgery that was carried out as the first of its kind in Nigeria. And I recall that there have been cardiac surgeries in Nigeria before now. The first one was at the University of Nigeria Teaching Hospital, Enugu, on February 1, 1974. And since then, we've had so many. So what makes this particular surgery the first of its kind? Is it the complexity? I think many of our viewers would like to know. Professor Adeleke, yes, you led the team, yes.
Good morning.
Good morning.
To you and to all our audiences. The surgery has been done before at University of Nigeria, Nsukka. But the complexity of the case that we are talking about is kind of unique. Tristate have done more complex cases as well in other institutions. Take, for example, we did at Babcock University, we did at UCH, and then also at Abbott. But the key about this case is the fact that the patient presented with unusual form of presentation. First of all, he passed out, and after passing out, we found out that he had electrical abnormality. So this electrical abnormality was what triggered our thinking to say that perhaps this is coming from your heart. The key thing is that if you are not really in tune into the cardiac, you see someone who coming with, complete heart block. Well, the first thing you want to do is just to go and put in the pacemaker. You put in the pacemaker, and that's the end of it. However, what was the cause of the complete heart block? That is the key. So because of us being there and having all the tools that we needed, we were able to quickly look for the other causes, which mainly come out to be the heart. And it turned out that the patient actually have blockages of the arteries. So now, not only that we have to be very careful in putting the pacemaker to save his life, but at the same token, if you put the pacemaker and then you increase the heart rate, patient will have a heart attack on the table. So now we have to really, play the game very well. So putting the temporary pacemaker, after that one, then go and put in the permanent pacemaker. And after putting the permanent pacemaker now, go and see whether or not you can do the bypass successfully. This is the kicker. Just as we're about to go for the bypass, we find out that patient was in kidney failure. So now we have to now resolve the kidney failure, because if we don't do that, the kidney may be permanently damaged. If the kidney is damaged permanently, then the patient has to be on dialysis for the rest of his life or need kidney transplant. So now we have to really tell that we treated the kidneys and successfully then took him for the bypass. So he had the bypass, then he went to kidney failure again, and then we have to put him on dialysis. So you can see the complexity of this case from the presentation, whereby he came in just with the electrical abnormality, and then, putting the temporary pacemaker, permanent pacemaker, then issue of the dialysis, and then go in and do the bypass. In the process, we also now found out that the patient also now have leakage of the valve, a major valve, and that was because of the blockages of the arteries, that the patient had. Now we have to also repair the valve. So you can really see in one single setting, you did so many procedures, something that could have actually increased the mortality of this patient. That is the key. It's not necessarily because of the fact that we have not done this kind of cases before, but the fact that the patient presented with complex cases, and that we have to take care of each of them, one by one. And they successfully, did end, and patient is alive, and they're walking around now.
Professor Adeleke, certainly an amazing job that was done by you and your team. And once again, congratulations on this success. Which brings me now to Dr. Lalude. I would like to ask you, when it comes to these surgeries, what is the usual success rate that we see coming out from these heart bypass surgeries? And how long did it take for you to prepare your team of 19 specialists for this?
Well, good morning.
Good morning.
I'm actually not a heart specialist. I'm actually a colorectal surgeon. However, my role is that of the group medical director of the hospital, and we were instrumental in designing this collaboration with Tristate to bring advanced cardiac surgery to Nigeria. So in terms of success rates, I'd have to defer to my cardiac colleagues to answer that particular question.
Okay, we'll quickly defer on that to Dr. Sanusi. Would you like to give us a bit more information with regards to success rates on these heart bypass surgeries?
Good morning.
Good morning.
It's nice to be on a morning show. So the success rate for heart bypass surgeries depends on the fact that the patient has a blockage and then all the other things that Professor Adeleke has alluded to. So the success rate with someone that has maybe a single vessel blocked could be as high as 98%. Someone who's had a major heart attack, has a leaking valve, is in renal failure, has more than 2 system failures. You can have success mortality rates, sometimes up to 50 or more %, depending on how the patient presents. So this particular patient had a lot of negatives, especially with the fact that the heart was involved as well as the kidneys.
Well, Dr. Lalude, let me come back to you. And my question is about cost. Cost is a big issue in any medical situation. either in terms of drugs or the intervention or the preparation or stay in the hospital. Now, how expensive is the cardiac surgery process? And considering the fact that many patients are indigent and cannot afford to come to a private hospital like yours, what do you think should be done about cost? First, the figure, and then is there anything that can be done to reduce cost? And how do we compare to hospitals abroad, particularly India, which is a major destination for many Nigerians who have cardiac issues?
Yes, thank you. The issue of cost is actually quite a thorny one because, as you can potentially see from the footage before, you need a lot of sophisticated infrastructure to deliver this kind of care successfully. On the day, there were up to about 19 people on the team in different roles employed, and that means you need 19 highly qualified specialists in their particular fields who are all involved in this one patient. You also need a lot of sophisticated machinery, such as a heart-lung machine. You need people who can use that, a lot of drugs. The patient will go to intensive care afterwards, which is actually quite an expensive procedure as well. So if you look around the world, cost can vary from very expensive in a place like the United States, where it can potentially cost between $70,000 to $100,000. Coming to India, the cost is less, but still highly significant, potentially up to about $20,000. It varies, or a bit less. But in Nigeria, historically, we've been able to do it for much less than that. However, the particular challenge with that is the fact that, as we all know, we don't really make very much in Nigeria. So all of the components of these procedures have to be imported, or may I say, the majority of the components for these procedures have to be imported, which then means that you need access to foreign exchange. It then means that there is susceptibility to variation in the value of the naira against the dollar. So a depreciation in the value of the naira will have a significant effect on the cost of delivering the operation. I think cost generally, when you look at the economy of Nigeria, as you say, we've been estimated to have the highest number of poor people in the world, about 60 to 70% of our population, and we don't have a developed unified healthcare payer approach at a national level. In fact, 70% of healthcare expenditure in Nigeria is through out-of-pocket, which is one of the highest in the world, if not the highest in the world, and is clearly not sustainable. And what that means is that there's a lot of restricted access, as you alluded to healthcare by indigent individuals within the country. So we need a unified, centralized approach. We must get away from the pattern where we rely, like this gentleman did, on out-of-pocket payment for procedures like this, and we must move towards a more unified, insurance-based approach where we have a large risk pool of people. That is to say, you have a lot of young people who are contributing but are not utilizing the system that much, and people at the upper end who are also contributing but are more likely to more heavily use the system. There is a big role for government within this to help structure adequately such a system, and also in terms of administration. So before I finish on that, I'd like to point out there is a system called Ayushman Bharat in India. It's a new, well, relatively new insurance scheme, which is administered by the state, which caters for the 500 million most vulnerable people in India. But what I want to point at is the level of money that is in that, where they provide for a family up to $5,000 per family, and that is the government scheme. So you can see that healthcare is quite expensive. America spends $3.3 trillion, about 18.5% of GDP. The UK spends about 130 billion pounds a year for a population of about 70 million people. So you can see that it's going to be a significant challenge for us as a country to address the issue of cost, particularly as we look at the economic headwinds that we're heading into now with the reduction in the price of oil and the pandemic that we're currently facing. So there is an issue with cost.
Certainly there is a significant challenge, and thank you for pointing it out and walking us through that. Now, staying on India and staying on the topic of medical tourism, Professor Adeleke, maybe I'll bring this to you. There is a model in India that I find particularly interesting, Narayana Health City, whereby you can get a heart bypass for $2,000. And this was a private sector initiative started by a doctor named Devi Shetty, and what he's been able to do is ensure affordable healthcare for everybody, but at a solid standard. Do you think that with proper insurance schemes in the country, we can, through the private sector, develop health models like this to fit in and fill key gaps that need filling? What is your take?
Well, thank you very much. If I actually may digress a little bit first, when we first started the open heart surgery, when I came back from the United States, I actually did not know how much to charge. So basically what we did was that we said, okay, fine. Majority of people, probably about 60–70% of the medical tourism destination is in India. How much do they charge in India? That's how we come out the cost, how much we should charge. So, and at that time, I think we were charging about $10,000. But then we felt that if we charge that, at least we are still saving patients a lot of money. They don't have to pay for the transportation, accommodation and all those. And then the family member will be able to see them, while they're having the surgery done, which is quite very, very important. And since then, we have been maintaining that. So I would say the cost of doing the operation in Nigeria is much less than the cost that you even incur when you go to India. Now, in terms of your question, yes, it is quite very true. This thing, as Dr. Lalude alluded, we have, if you look at the population, congenital heart defect, it's about 1% of the population will have congenital heart defect to start with. And now we are going to the acquired, which is what our patient had. So if you look at that, and you have majority of people, as we said, have insurance, and when we have the pool of insurance people, then you have more people who are utilizing, because a lot of people still going abroad. If you keep those people in Nigeria, having the surgery done in Nigeria, obviously now the cost of doing the operation is going to be low. When we started, we were buying the valve, that is a valve replacement. We were paying about $2,500 for the valve because we don't make anything in Nigeria. So we had to buy it using the foreign exchange, $2,500. I think today we are paying probably about $1,500, and the reason is because the volume had gone up. So the more people you have utilizing the services, then the less the cost will be. So I believe if we go to the insurance scheme and then we utilize, particularly if we encourage the manufacturing in Nigeria as well, we can really see the cost really getting to that number.
Well, Doctor, I think Dr. Sanusi, I would like to ask you this: what kind of cardiac problem is most prevalent in Nigeria? Is it congenital or, acquired? Is it the hypertensive type or the rheumatic type or the ischemic type that is most prevalent? And what is the prevalence in terms of, adults and young people? And then the real question that I would like to ask is every cardiac problem surgically correctable, or there are some that are just death sentences?
Thank you. That's a very good question. So the surgical problems those that are surgically corrected are mostly structural problems. So there are different types of different categories of heart disease. Obviously, hypertension is very common in black people, and that is usually just treated with medication with the cardiologist. But when it comes to invasive problems like invasive cardiology, cardiac surgery, that's when there's usually structural defects. Those of these, the commonest is probably congenital issues. We see a lot of congenital issues in Nigeria. The prevalence is supposed to be 0.1% of the population, meaning that 1 in 1,000 children born will have some kind of heart defect. Now, 1 in 1,000, the heart defect may sometimes correct itself over the first few years of life, maybe a small hole in the heart that will seal, but a significant amount will now show up as the child gets older. Sometimes when the child is really young and it's a large defect and they become symptomatic very quickly and have to be acted on quickly. Heart blockages is actually, when I was in medical school, we were taught then, mostly by professors, that, oh, Nigerians, because of our diets, we don't have heart blockage, we don't have ischemia, meaning lack of blood supply to the heart. Well, I think that has changed. I don't know if it's, when we were in medical school then, we had no way of diagnosing, really. There was no cath lab, so it was like we have at Reddington and other institutions today. So we now find out that it's actually quite common. One of the commonest surgeries that we do in Nigeria today, we do, apart from the children that come in droves, we do a lot of heart bypass. And then we have the valve problems as well. So the valves, in sub-Saharan Africa, we have a lot of what we call rheumatic fever that goes on to rheumatic heart disease. The incidence around the world is decreasing now, but we find many people now coming to us in their 20s and their 30s that have continual damage to their heart valves. So with that disease, we say it's a disease that keeps on giving because, you know, the original insult happens when as a child, maybe 20 years ago, and it just continues to damage the valve until the patient can no longer cope. So this is very common in our environment. We see a lot of patients, and especially from northern Nigeria, we see a lot of people come to us with rheumatic disease.
Thank you for this clarification, Dr. Sanusi. Now, one thing is clear, one thing that we have seen from this situation with COVID-19 is that we need more training centers for our doctors and our healthcare workers across the country. So, Dr. Lalude, I'm going to come back to you and ask, what would you like to see being done both at government level and also, of course, at private sector level to increase the number of training centers that we have in the country for healthcare workers?
Well, thank you. I think certainly there needs to be a deep collaboration between both the public sector, that is government, and the private sector. Certainly, one thing we do need is we need significant investment in infrastructure. Successful medicine will be a marriage between personnel, experienced personnel who are capable, and also the infrastructure. There is a silent revolution going on in Nigeria which is not quite appreciated by a lot of people. So I'm sure you potentially tell by my accent that I've spent a lot of time in the UK. I spent most of my medical life, about 30 years, in the United Kingdom before coming back to Nigeria 3.5 years ago. The same with Professor Adeleke, who spent 45 years. And there are lots of my colleagues now who are coming back, some to stay, some to render service and then go back. So I think there is potentially a brain gain here, where you have highly experienced clinicians who are sort of middle towards the end of their careers. They have a lot to give. And for them to be adequately embedded within the system, particularly to transfer skills to the local population of doctors. And we'll find that would potentially work quite well. The other thing is that we do need to, as Professor Adeleke alluded to, is to increase our volumes of patients that can afford sophisticated surgery, because you need that volume for training. So when I trained in the UK, I trained in the National Health Service, which caters for about 95% of the UK population, delivers healthcare needs. And what that meant was that you had very large numbers of patients. And I was fortunate to train adequately with a very large number of patients at a very high level. And then you will find that in the private sector in Nigeria, the private sector is probably best placed to invest money in the very high end for now. Hopefully, eventually, the public sector will be able to do the same, but you potentially find, for instance, that a place like St. Nicholas that routinely does renal transplants, that's kidney transplants, other hospitals like First Cardiology, which also provides cardiac services, that there has to be some sort of symbiosis between the educational infrastructure in the public sector and these private institutions. And what would normally happen abroad is that people would finish their training in the public sector and then go on to these specialist hospitals for what we would call a fellowship. They'll go and spend 1 to 2 years after their training to now super specialize. That is to have additional exposure to sophisticated procedures, which they will then take back into their careers. I might add that if we go back about 30, 40 years, Nigeria was, I would say, pretty well advanced. Looking at a hospital like UCH, back when it was in its heyday, its glory days, it would cater for people coming in, relatively high-level people coming in for abroad for treatment there. And if you looked at the quality of treatment in a hospital like that, it was equivalent to hospitals abroad. So we can get there, but we do need to finance appropriately, but we also need a plan. We need a plan, we need a correlated plan by government to attract people in for training, for us to move things forward.
Well, thank you very much, Dr. Lalude. But Professor Adeleke, let me come to you. Dr. Lalude has already talked about brain drain, he's talked about training. But I would like to ask you, how large is the community of cardiac experts in Nigeria? And then, of course, do we have enough? Has there been a negative impact heavily in terms of brain drain? Your team, you led a team of 19 specialists. I imagine that not all of them are cardiologists. There will be anesthetists, there will be intervention experts, there will be perfusionists, there will be hematologists. Now, what do you think government needs to do in terms of either expanding the community of experts in your field, or we have enough? And then, of course, you and Dr. Lalude came back home having practiced abroad. When you look back now, do you think that the circumstances at home are encouraging enough for more people to return home?
Thank you again very much. I think it's about 9 years ago, I was at a Mayo Clinic for a conference. And the Nigerian doctors at the time, they saw me, they knew I was there, and they asked me to come and give them a talk, a pet talk. So I said, okay, fine. What do you want me to talk about? And contrary to my expectation to say, talk about cardiology or cardiothoracic surgical or whatever, the topic was how to, how to leave United States and come back to Nigeria, in order to transition from US to Nigeria. So there were about 36 doctors there. So I asked a question, I said, okay, fine. Let us say that Nigerian, the economy, the environment is only 50% conducive. What percent, how many of you would like to go back to Nigeria? Out of the 36, 35 raised of their hand that they will go back to Nigeria. And the reason is very simple. Nigerians, they love their country and they want to come back. Whoever thought that I would come back to Nigeria, So this brain drain that we have been calling it can actually be the brain gain for us, because a lot of Nigerians have been outside Nigeria, in UK, other European countries, in North America, even in Australia, everywhere. And they are well trained. And those are the people that you really need to bring back home find a way to get them back home. I went to China about 7 years ago, and I was so shocked, that how can China, who truly do not believe in what we believe in the Western world, before economically, how do they dominate everything in the healthcare sector and also financial? And the Chinese friend that took me there, they just said, ha, ha, ha. They said ABC. I said, what does that mean? And I thought as simple as ABC. They said, no, American-born Chinese. Those are the people they brought back home. And if you look at Nigerians, thank God our genes have not been diluted. We are brilliant people. It doesn't matter where you go all over the world, you will see Nigeria in the high end. So our Nigerian doctors are quite very well trained, and that's why they shine wherever they go outside Nigeria. But at the same token, there is not adequate training to the level where they can do what we are doing now. So what do we need to do? We need to marry the Nigerians in diaspora with the local Nigerians so that now we can all put our resources together and train the young doctors in every specialty that we have. We do not have, and that is the problem, we do not have enough manpower to do, even if we want to take care of all Nigerians' cardiac program, we don't have enough manpower. How many perfusionists do we have in Nigeria? Perfusionists are the technologists that actually stop your heart, that do the operate the heart-lung machine. In the whole federation, I think we only have about 3 or 4 for the population of 208 million people. So that is inadequate. So the training is a fundamental part of it, and the government has to step up in that one. In providing the infrastructure, and as Dr. Lalude alluded to, we have to collaborate with the private institutions that have it. At least we have now about 5 institutions that Tristate is involved with that can adequately do the training. So now all those, our training, and we're already doing that as well, with the Medical Society of Nigeria, to actually bring those people to this facility to be able to do the training. But the government have a lot to do. We cannot move forward without having the manpower. And the only way we're going to have the manpower is to train them. And you can't be sending them abroad because they are very expensive that way. And even look at the expatriate that we brought in here. The amount of money that it cost us to hire one registered nurse, it's probably the same amount it cost me to hire maybe 5 to 7 local Nigerian nurses. So you can really see the expense of it. Until we do that, we are not going to move forward. But I think there is a avenue now. Reddington Hospital have all the infrastructure that we needed for the training. Babcock University have been doing it for almost about 4 or 5 years now. They have it. Afe Babalola University is another one, that have it. You put all these institutions together now, and then you can now improve, the other institution, and let us carry out the training, which we already started, by the way, so thank you.
Thank you very much, Professor Adeleke. And yes, there is certainly a way for us to turn that brain drain into brain gain. Now, Dr. Sanusi, let me come back to you and ask you something with regards to recent statistics that came out. The Presidential Task Force letting us know that what we have seen since the genesis of coronavirus in Nigeria is a 50% reduction in outpatient cases from 4 million patients to 2 million patients. Now, what would you say are the reasons for this? I mean, the Presidential Task Force has said that this is also due to a lot of hospitals rejecting patients, etc. So is this something you're experiencing at Reddington? What would you say are the key reasons for this, and anything that you would like to analyze in that regard?
Well, in my practice, we have been working in spite of coronavirus and pandemic. We've taken measures to try and keep ourselves safe, but one of the reasons I think that there's decrease in outpatient or in patients coming to the hospital is because, one, the patients are scared to come to the hospital, and they have to really feel bad before they make that trip. And then the doctors are also very skeptical. I'll give you an example. When we started coming back at Babcock, for example, we had a meeting and said, we want to work, but we need to make sure that we're safe. So we said we're going to get antibody testing kits and test every patient we're going to operate on. And we've been doing that. A patient came a couple of weeks ago and wanted to have a procedure done. We tested him with our antibody testing kit, and he was positive. We sent him to the government facility to have PCR testing, and he was found to at the government facility he didn't get his results back. So after 2 weeks, the patient came back to me yesterday, over 2 weeks actually. He couldn't get results back. So we said, we've had no symptoms at all. Let's test you again. We tested him, lo and behold, he was still positive. And we're like, oh, maybe it's false positive. Maybe it's just, this guy looks so healthy. And but the team said, we all have to be very careful. We don't have the full PPEs for surgery. We have enough to protect ourselves, but to really do surgery on this patient. So fortunately, we were able to, through one of our microbiologists, we were able to find out, try and pull strings, or and find out if what this patient's result for the PCR testing was. Only for me to get a call at 11:30 p.m. yesterday that the patient was actually COVID positive. And so that means that's putting the whole health team at risk without the full PPEs that are needed to protect the patient. So it comes both ways. The health team has to be protected because there are not that many specialists in the country. If a team gets sick, then it's going to affect a lot of patients. So we have to keep testing. I believe in lots of testing. And when we're open for sick patients all around at Reddington, the patients get tested all the time before procedures are done. Thanks.
I'd like to come back to you. We have just about 2 minutes to go, but we can't let you go without taking some medical advice from you. Heart diseases can be either congenital or acquired. Now, for the acquired category, what advice do you have for everybody as to how we can take good care of our heart?
Well, thank you very much for that question. That's a very important question. And I would say that we already talked about congenital. When you get to our age, particularly all of us that are in the middle class, you will see that the cardiac disease you're going to have are acquired. And acquired cardiac disease, as Dr. Sanusi had alluded before, really stems from just hypertensive heart disease, which is the most common form, the one that our patient had, which is the blockages of the artery and the valvular heart disease. And of course, people who have infection. But I would say the acquired one, I always tell people, know your numbers, because they're risk factors. If you don't have any risk factor for heart disease, your chance of having heart disease is very low. And what are those risk factors? Number one is hypertension. Hypertension is so common, it's so prevalent in our society. As I said before, in fact, if you look at in sub-Saharan Africa, 1 in 3 sub-Saharan African above the age of 18 will have high blood pressure. So you really need to check that one. Diabetes, high cholesterol, stress, and those people who smoke cigarettes, which thank God, majority of us do not have. And then you got to go and see the doctor and get yourself checked out periodically.
Thank you very much.
Thank you very much, Leila. I think we should
round this up. This has been a great conversation this morning.
So thank you very much, Dr. Lalude, Professor Adeleke, and Dr. Sanusi, for sharing your insights with us on heart diseases and the health sector in Nigeria.
Absolutely.
Thank you very much indeed.